السلام عليكم ورحمة الله وبركاته، وأسعد الله جميع أوقاتكم بكل خير. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وبعد. Our lecture for today is about meningitis for the 5th year medical students. Usually we give this lecture in the beginning of the course of the groups of the 5th year medical students, because usually we see cases of meningitis in the pediatric departments, despite the immunization coverage against many of the strains or many of the types of meningitis is there in Gaza Strip. So in the beginning of our lecture, we will speak about objectives. So by the end of this lecture, each student will know about epidemiology of meningitis, pathogenesis, clinical picture, diagnosis of meningitis, treatment of meningitis, different types of meningitis, and prevention of meningitis. First of all, regarding simply about the definition of meningitis, it is inflammation of the meninges and cerebrospinal fluids, and there are many infectious agents, include bacteria, viruses, fungi, and other organisms like protozoa and rickettsia can cause meningitis. Here, as you see, this is the meninges. We have the pia mater covering the brain, then the arachnoid and dura mater, and this picture will show the normal meninges and the infected meninges. As you see, there is here the congestion, edema, redness, swelling. All these things are available after infection. Regarding the epidemiology, simply the type of meningitis will be according to the age group. In the neonates below 28 days, usually we have gram-negative bacilli meningitis, which is 50 to 60%, while group B strep is 20 to 40% of cases, and this may extend up to 3 months. Again, Listeria monocytogen is very important in the neonatal period and can infect 2 to 10% of the cases, and this Listeria may extend up to 3 months. Again, we will have Haemophilus influenza and strep pneumonia, while in the children beyond the first month, usually we will have Haemophilus influenza, Neisseria meningitis, and Streptococcus pneumonia. Of course, the number of cases of Haemophilus influenza and Streptococcus pneumonia is decreasing too much after starting of the vaccine in Gaza Strip, but Neisseria meningitis, still we don't have the vaccine here in Gaza Strip, although some of the European countries, they are using the vaccines against Min B and Min C strains, and again after meningitis A later on after the first year. In immunodeficiency, we have more organisms like Pseudomonas, Staph, or Salmonella. Regarding the Listeria monocytogen, it is a small gram-positive bacillus. Just here we will mention some notes about Listeria to know about Listeria monocytogen, because it is not famous to see it in childhood diseases, but in neonates may cause meningitis, and also it has a role of infections in adults. The Listeria monocytogen will cause 8% of bacterial meningitis. the mortality rate is 22%. This means every 5 cases we have one mortality, and this is very significant. That's why we have to keep it in mind, and any case suspected meningitis, in neonate we have give an empiric antibiotic that covers Listeria monocytogen like the ampicillin. The Listeria monocytogen, it is widespread in nature and has been isolated in the human stool of 5% of healthy adult, and this is of course significant. The most of the human cases appear foodborne, يعني the transmission is through the food, and this is important point, especially in adult. Up to 70% from raw meat, vegetables, and other foods can cause this meningitis. The outbreaks have been associated with consumption of contaminated milk and cheese. That's why we have to keep that in mind, as what happened in brucella and other diseases. What are the risk factors for Listeria monocytogen infection? This is in general, not in neonate. Number 1, the pregnant woman. This is risk factor, more in pregnancy, with pregnancy. Number 2, infants and the children. But in the first 1 month of life is much more. Elderly individuals above the 60 years old. Immunosuppressed people. People with liver disease and renal disease. People with diabetes. People who are receiving iron overload like hemoglobinopathies and hemochromatosis due to frequent hypertransfusions. Now simply about Streptococcus pneumonia, which is well known, and you know a lot about Streptococcus pneumonia before, but briefly we'll speak that Streptococcus pneumonia is a gram-positive coccus. It's a common colonizer of the human nasopharynx. About 5 to 10% of healthy adults carry the pneumococci, and about 20 to 40% of healthy children. So it is colonized in the throat of the children more than adult. It will cause meningitis through corroded plexus, sinusitis, or otitis media. Meningitis in basilar skull fracture and CSF leak. This is very important, and we speak, and this is a risk factor of course, and we have to take care and to suspect, if there is any CSF leak, if we have recurrent Streptococcus or pneumococcus meningitis. It is associated with pneumonia, sinusitis, endocarditis, all the three, they call it Austrian syndrome. There is increased risk in hypersplenism, hypogammaglobulinemia, multiple myeloma, glucocorticoid treatment, defective complement, early complement C1 to C4, diabetes mellitus, renal insufficiency, alcoholism, malnutrition, and chronic liver disease. Now we speak about risk factor for meningitis. The risk factors for meningitis in general, not for a specific organism. This is decreased immunity to particular organism, and we will speak in the next slides about that. If there is a recent upper respiratory colonization with the person, if there is close contact to a patient, if there is a crowdedness, poverty, it is more in black people than white people, and more in male than females. Here, the decreased immunity to organism, which is associated with infection, especially meningitis. If we have if you have late complement deficiency from C5 to C8, this will cause recurrent meningococcal disease or recurrent meningococcal meningitis. If we have decreased properdin deficiency, it will cause lethal meningococcal disease. If we have splenic dysfunction, will cause pneumococcal and Haemophilus influenza type B meningitis. If we have T lymphocyte defect, this is more commonly to have Listeria monocytogen meningitis. If we have CSF leak, as we mentioned, either congenital or acquired, it will cause pneumococcal meningitis. That's why if you will find any recurrent pneumococcal infection, you have to look for CSF leak, and to examine the rhinorrhea or the fluid coming from the nose to be sure that it is CSF, not mucus. In cases of meningomyelocele, we will have staph meningitis, and in cases of CSF shunt, if we have shunted due to obstructive hydrocephalus, this is more commonly to have coagulase negative staph meningitis. What is the pathogenesis of meningitis? Now the mode of transmission is through droplet or through the secretions from the patients. So it comes through the upper respiratory passages. Majority are hematogenous in origin. It will spread from the throat to the blood. Organisms have virulence factor against normal defense mechanism, including proteases and polysaccharidases. This is virulence factors of the organism. As we mentioned regarding pathology and pathogenesis, this picture shows that there is here infection or colonization in the throat, and the infection will be through droplet and through secretions of the patient. The incubation period of meningitis is 2 to 10 days in the median of 4 days. 4 days, the incubation period of bacterial meningitis. How the pathogen will enter the CSF? Usually there will be nasopharyngeal colonization, nasopharyngeal epithelial cell invasion, will go to a bloodstream, then this will cause bacteremia with intravascular survival. This will, after that, will cross the blood-brain barrier and enter the CSF to cause meningitis. Regarding the pathology, what will happen if there is infection? This infection will cause exudate in the subarachnoid space. The small and medium-sized blood vessels will be infected, and that's why it may cause infarction in the areas supplied by these small blood vessels, and we will see that in the picture. The infection may cause blockage of the normal CSF in any place, especially the aqueduct of Sylvius, and this will cause hydrocephalus. There will be spinal nerve inflammations, and this inflammation will cause the meningeal signs we use to diagnose the disease. And again, there will be cranial nerve inflammation like the optic nerve, the 3rd, 7th nerve in neuropathy. And there is increase in the intracranial pressure due to cell deaths and cytotoxic edema, due to cytokines which induce capillary permeability, through increased interstitial pressure, CSF obstruction, and syndrome of Syed-H, syndrome inappropriate antidiuretic hormone secretion. By this, there will be increase in the CSF protein due to this obstruction or due to this infection, and increase intracranial pressure, and this increasing of the protein, which when we'll do lumbar puncture and examine the CSF, there is increase in the protein because of increasing permeability of the blood-brain barrier because of infection. Here, as you see, this is exudate in the dependent areas of the brain. This is the brain, as you see, some exudate in the grooves here and the dependent areas here in the sulci. And here, you know, large number of polymorphs. All these dots are polymorphs. Inflammation in the wall of the vessels. This is, as you see, these blood vessels are inflamed, and that is cause infarction in the brain around these blood vessels. Here, from the complications of meningitis is the brain abscess. Here, this is post-mortem, and this is, you know, the CT showing a brain abscess. One of the signs of meningitis in the infantile period is hydrocephalus, as you bulging and tense anterior fontanelle and sitting sun. This will cause, you know, this is, you know, causing, hydrocephalus and the enlargement of the size of the head. How we will diagnose meningitis? First of all, the importance of the history, and why we teach you the history, because this is very important. And as we told before, maybe 80% of cases can be diagnosed only from the history before you are going to physical examination or before you are going to investigations. So we have to take this history thoroughly, and every point in this history is important. For example, the personal history, the name. You know, some of the, for example, families, they have some sort of immune deficiencies that predispose to meningitis, and this is hereditary diseases running in the family. The age group, you know, the organism will depend on the age group and sex. We told that males more than females. The address is important, especially if we have epidemic in one of the quarters in the city. So any person will come from that area, we have to examine him thoroughly and to suspect in meningitis until proved otherwise. The complaint and the duration of complaint, of course, is important. And if the patient has received the drugs, you know, to take in mind this partially treated meningitis. The history present illness in details, it is very important, and whether the patient, what treatment he has, and the progress of signs and symptoms. The past history of contact to people is important. That's why in the history, in the lecture of the history you have given before, during the history present illness, in case of infection, we have to write the history of contact. Vaccination is important to know whether this child is vaccinated against meningitis or not. For example, Haemophilus influenza type B given or not. For example, pneumococcal conjugate vaccine is given or not, or if he is living outside, to see if he received meningitis vaccine or not. Family history is important about crowdedness, and even social history about housing, relation, and so on, which are considered, as we mentioned, as risk factors. So history is very important in the diagnosis. Then we look for clinical manifestation. Of course, there is infection, so there will be fever. In smaller and younger children, of course, they don't have, you know, the usual signs in children. These in infants and young children, you may not find, especially in infants, the other signs like Kernig sign. So only it is sufficient for the baby to have neck rigidity. When you support the baby, you feel that there is neck rigidity or bulging anterior fontanelle, for example. There will be some sort of cerebral dysfunction like confusion, delirium, decreased level of consciousness, bulging anterior fontanelle, and photophobia. But these symptoms in the neonate, it will be not there. That's why you will find in the neonate sepsis-like illness, sepsis-like symptoms, like poor feeding, irritability, lethargy, mottling, and convulsions. The clinical manifestation, when you examine the patient, we look for the Kernig sign, which will be positive. A Brudzinski sign in 50% of bacterial meningitis will be positive. We will look for cranial nerve pulses like the 4th, 6th, and 7th nerve. We look for convergence. Here, just this picture, illustration for you to remember the clinical manifestations you will find. From, if we told that there will be, vomiting, this vomiting will be severe, and projectile vomiting. There will be fever, headache, neck stiffness, as we mentioned, light, a blurring of vision and light aversion, drowsiness, maybe some joint pain and some sort of meningitis, and convulsions, of course, or seizure problems. This is the Kernig sign. Simply, you will flex the hip to 90 degree and then extend the knee, extend the knee. Then there will be severe pain in the back, and maybe also there is flexion of the other knee there, or flexion of the neck. Now, Brudzinski sign. If you flex the knee like this, then will be followed flexion of the head, will cause flexion of the knees. The diagnosis, so we will assess increased intracranial pressure. So we have to do fundus examination, fundoscopy, and every student or every doctor should know how to examine the fundus. Fundoscopy is important. Some of the doctors, they will send only simply to ophthalmologist to look there. Although papilledema is late sign, but we have to do fundoscopy to check for papilledema, because it is a sign of increased intracranial pressure. And again, we assist for focal neurological finding. We can defer the lumbar puncture until CT scan or MRI will be done, or you can do it, thoroughly with fine needle. The gauge of the needle will be a fine needle, for example, 25 needle. So this will not cause sudden drop of the pressure. If you suspect meningitis and you will be awaiting for neuroimaging, better for you to do a blood culture and start empiric antibiotic. Blood culture mostly will be positive that time, so you can do lumbar, you do blood culture and you start the empiric antibiotic. This is the papilledema. It is very clear, congestion, and the optic disc is hazy and so on. This is the cerebral edema. The left side you see the normal CT, and here, as you see, there is generalized of loss of the gray and white matter. You cannot differentiate even the gray from the white matter. And this is by the MRI, especially if you have meningitis with collection. Here you can see the collection in T1 and T2. Diagnosis. So during the diagnosis, we obtain CT scan before lumbar puncture in patients with. So those patients, better to do CT scan. Immunocompromised state, history of CNS disease, a new onset convulsion, papilledema, altered level of consciousness, and focal and neurological signs. The diagnosis is important. The most important is the lumbar puncture. And for the lumbar puncture, once it comes to your mind, you have to do. If you suspect meningitis or encephalitis, you have to do lumbar puncture. Whatever it is, it comes to your mind. The same, usually we tell the students, the same as appendectomy. Once you suspect that there is appendicitis, better to do appendectomy to avoid the problem of perforated appendix. That's why here in meningitis, once the lumbar puncture it comes to your mind, better to do lumbar puncture because this is a serious disease. What are the contraindications of lumbar puncture? You know lumbar puncture is important, and you know it is important again in the OSCE examination. There will be stations sometimes about to write a consent, you know, from the patient or for the watcher, you know, to do lumbar puncture. So this is important to know the contraindications of lumbar puncture. Number one, coma, signs of increased intracranial pressure, if there is shock, if there is cardiovascular or respiratory compromise, if there are focal neurological signs or convulsions, if there is coagulopathy problems like DIC or hemophilia with the patient, if there is thrombocytopenia, if there is local infection at the site of doing diffuse at the site of the lumbar puncture. If there is contraindication of lumbar puncture, so we have to do a blood culture and start the empiric antibiotic. Assessment prior to lumbar puncture for contraindications, the CT scan we mentioned, and don't delay antibiotic whilst waiting for the CT. Here the normal CT scan does not tell you that the patient does not have raised intracranial pressure, and herniation may occur even in the presence of normal scan. That's why these are helping the CT or will help you, but you know you have to take all things in consideration. What are the complications of lumbar puncture? Again, failure to obtain a specimen, usually if you have a traumatic giving a bloody CSF. Anyhow, there is advice for the doctors. You know, if you feel that it is not going with you simply the lumbar puncture, better to ask your colleague, whatever he is, whether even he is more junior than you, if you feel that today is not going with you, better to ask, you know, your colleague to do that. Because sometimes simply you will do, for example, vein puncture to fix the cannula for the child, and you find you know that it is not coming, although it is a clear tube, the vein clear tube. So in this area I advise you better to ask somebody else. This is better than you will try in the spaces, all the spaces, you know, for the below the second lumbar vertebra or below the third or like this. So if we lose these you know spaces, then no more. If all of them are traumatic, then you will fail. Better if you failed in one space, you ask somebody else, or if you fail in two spaces, you better to ask somebody else, you know, from your colleagues to proceed and do the lumbar puncture. There will be transient, persistent paresthesia and numbness, and this is very important. You know, sometimes we tell the patients or the watcher about that thing, but you know, don't you know let them afraid from the procedure, and they may refuse if you tell them that it is common. But usually we tell that most of the cases we do, you know, there will be no complication, but sometimes simple things and will fade away after that. There will be a spinal hematoma sometimes, or abscess, maybe especially of those with hemophilia, although it is you know, of course it is contraindicated to do for them. Tonsillar herniation, which is extremely rare, in the absence of contraindications above. That's why we keep that in mind, and sometimes we have to do lumbar puncture with a thin needle. Better when you will do lumbar puncture to collect CSF in 3 tubes. For cells, differential, proteins, and sugar. Second tube for gram stain and latex, and the third tube for the culture. Sometimes we hold one tube, especially in certain situations, to keep it for viral PCR or fungal mycobacterium or mycobacterium cultures. We will do CBC and blood sugar, blood culture, skin smear, and culture. CSF, this is skin smear if there is meningococcemia, to know that there is meningococcemia with meningitis or separate meningococcemia. The CSF finding, it is important. Once you will put the needle and the CSF will come out, the pressure will be, if it is gushing, so this is going with bacterial infection. You will look for the appearance if it is hazy or disturbed, or not clear. So this one is going also with increased the cells and maybe bacterial meningitis. Then we will take the cell count and differential, glucose and protein, and we will do gram stain and culture for the CSF. Simply here regarding the CSF, this is the normal, this is in bacterial infection, and this is in viral infection. Of course, in bacterial infection, the pressure will be here more than 30 centimeter water, while in viral infection, the pressure will be normal or mildly increased. Regarding the appearance, the CSF will be turbid in bacterial meningitis, while it will be clear in viral meningitis. Proteins in bacterial meningitis are high, more than 1 gram per liter, while in viral meningitis they are less than 1 gram per liter. Glucose will be decreased in bacterial meningitis, while it is normal in viral meningitis. The gram stain usually 60 to 90% is positive, and this is important. That's why we should not ignore the latex or antigen screening for the patient, for the CSF of the patient. Gram stain will be negative in viral meningitis, especially this, latex or antigen screening is important in the partially treated meningitis, because it will show usually give idea about the organism causing meningitis. The glucose will be decreased, in bacterial meningitis. Maybe it will be normal or even slightly increased in viral meningitis. Here the cells will be in bacterial meningitis more than 500 or even more than 1,000. But viral meningitis usually it is less than 1,000, and this is according to the protocol. Sometimes they consider the 500 cells. Other things, if bacterial meningitis, usually the polymorphs are more high, 90% or more, while in viral meningitis you will find the monocytes. And this is the percentage of monocytes to polymorph. 10%, 10% have more than 90%. This polymorph, 30% have more than 50 polymorphs. The lumbar puncture changes after antibiotic. This is important to know it is partially treated meningitis or not. So prior to antibiotic use, reduces prior antibiotic use will reduce the sensitivity of CSF gram stain by 20% and CSF culture by 30%. This is important. And it takes 24 to 36 hours of therapy before that 90% of the CSF culture will be sterile. So usually it will take 1 to 1.5 days before the CSF will be sterile. And it takes 2 to 3 days of therapy to change the white blood cell count in the CSF in a true bacterial meningitis. So prior treatment is no excuse for not doing lumbar puncture. Diagnosis: there are some rapid tests like counter immunoelectrophoresis and latex agglutination. PCR is very important, and we use it here especially for viral meningitis. CT and MRI, MRI are of little role in diagnosis of meningitis, so obtain if suspect, increase intracranial pressure to know that. Additional test, the CBC and differential, of course, will show that it is bacterial, going with bacterial or with viral meningitis. Blood culture are positive in 80 to 90%, so it's very important to do blood culture, especially if you fail to do lumbar puncture. Chest X-ray sometimes it is needed, electrolytes and renal function also. What is the treatment of meningitis? Yani once you will do the lumbar puncture and before waiting for the result, you start immediately empiric antibiotic. This empiric antibiotic will be according to the age group. If in neonatal age group below 1 month or below 28 days, you start ampicillin and cefotaxime. If more than 1 month, better you start ceftriaxone and vancomycin. You know, steroid is given as supportive treatment, and we will discuss while we are giving steroid. What is the duration of treatment? This duration of treatment will depend on the type of the organism you found it in the culture or in the latex. So the average of 10 to 14 days, but here in Neisseria meningitis usually 5 to 7 days, Haemophilus influenza 7 days, Streptococcus pneumoniae 10 to 14 days. Better to keep it for 10 to 14 days. Strep agalacti is 14 to 21 days. This is rare, of course, and we don't see it. Aerobic gram-negative bacilli for 3 weeks. Complete 3 weeks, 21 days. And again, Listeria monocytogen, especially in neonates, we have to give at least 3 weeks duration treatment. During the treatment, we give supportive care, fluids, treat of shock, or if there is DIC. Steroid is very important in bacterial meningitis. So steroids will stop the effect of host inflammatory response because of fragmentation of the bacteria and the toxins from that. Most benefit seen with Streptococcus pneumonia and Haemophilus influenza to give steroid. Shortly, you have to give the steroid shortly or along with the antibiotic. Don't give it after the antibiotic treatment. It will be given with or before the antibiotic better. What is the differential diagnosis of meningitis? CNS infection like abscess or encephalitis will cause the same symptoms. Viral infections, viral meningitis, or tuberculous meningitis or Lyme meningitis. Rickettsial meningitis, we told that rickettsia can cause also encephalopathy. Cerebral vasculitis, subarachnoid hemorrhage, and neurosyphilis. How we will prevent meningitis? Of course, prevention of meningitis depends on the vaccines. This is our, vaccination schedule, and as you see, we give the Haemophilus influenza type B, and we started to give the PCR, and we discussed to you in the previous lecture the immunization schedule. As we mentioned, we will give in this schedule first in the second 2 months and 4 months and 1 year 3 doses of PCV, pneumococcal conjugate vaccine. And we will give Haemophilus influenza type vaccine, type B vaccine. This will be included in the Penta vaccine. Haemophilus influenza type B vaccine will be included with the Penta vaccine. Pentavaccines means DPT, hepatitis B, and Haemophilus influenza type B. All of the three vaccines will be given in one dose, 0.5 cc. And this will be given at the age of 2 months, 4 months, 6 months, then booster doses after the age of 1 year. So again, in developed countries, some countries in Europe and there, for example, Spain and the UK, they are giving, the meningitis vaccines, either routinely or according to the risk group. Routinely given meningitis B and meningitis C vaccine, and this is really, we hope that it will come sooner, not later, to our country to give meningitis vaccines B and C, and meningitis A vaccine, of course, it is given later on. And as you know, we give also meningococcal vaccine, as we mentioned in the lecture of meningitis, to people who are going to pilgrimage. This is, especially above 2 years of age, this vaccine will protect them from meningitis due to exposure during Al-Hajj season. The complications of meningitis, the convulsions, seizure, SAD-H, we told, syndrome of inappropriate antidiuretic hormone secretion, subdural effusion, collection, and that's why we have to follow the patient. Now, if we start antibiotic, we expect that the temperature will start to be reduced gradually and may fade away within 3 days or more. But if we have second rise of the temperature, we have to suspect, subdural effusion or abscess, or sometimes a drug fever. We have to differentiate and we have to follow the patient. Brain abscess is an important complication. Long-term sequelae of meningitis, really it's a problem if it is reaching 30% of children, and some will have hearing problem or vision problem or something like that. So the CNS sequelae, including nerve deafness, as we mentioned, cortical blindness, hemiparesis, quadriparesis, muscular hypertonia and ataxia, mental motor retardation, learning disabilities, obstructive hydrocephalus, and cerebral atrophy. And usually in our country, really, and in our hospitals, after treating this patient, we find a very small percentage of people, they will have the sequelae. But the presence of the sequelae, even if they are minimal, we have to follow the patient. Every patient with meningitis should be followed in the outpatient clinic and should be examined frequently and thoroughly regarding, the hearing assessment and the vision assessment and so on. The hearing impairment will be mild to severe impairment of hearing is noted in as many as 20 to 30% of affected children, especially Haemophilus influenza type B disease. But this is less common in other pathogens. And there is here note that early administration of dexamethasone reduces the incidence of audiology complications in Haemophilus influenza type B meningitis. That's why we give steroids before the start of the antibiotic. What is the prognosis for meningitis? Even with appropriate antibiotic, mortality rate of bacterial meningitis is significant. So there may be mortality rate, pneumococcal meningitis about 25%. Of this is percentage of the mortality rate, but not the percentage of the, as in general. So, in pneumococcal meningitis, the mortality rate will be more. Neisseria after that, and Haemophilus influenza, the least mortality rate, which is 8% only. There will be in the prognosis permanent neurological sequelae, as we mentioned, in 1/3 of the patient. This is about 35%, like hearing loss, blindness, mental retardation, hydrocephalus, convulsions and ataxia, and cerebral palsy. What are the poor prognostic factors in patient with meningitis? In young age, long duration of illness prior to antibiotic, neglected. Late onset convulsions, coma at presentation, if there is shock, low CSF white blood cells. This means the defense mechanism or the immunity is weak of the person. If there is low CSF white blood cells, while you can see the bacteria on the gram stain. This means the bacteria is available, but no response for that, and this is one of the risk factors. Keep in mind, because this is maybe, as you know, that in cases of meningococcemia, which is with high mortality, if it is associated with meningitis, the prognosis will be better than the meningococcemia without meningitis. If you diagnose meningitis, this means there is immunity and there is white blood cells there, and this is immunity of the patient. So meningococcemia with meningitis has better prognosis than meningococcemia without meningitis. Immunocompromised state also it is for poor prognosis. Now we will start for questions. Regarding questions, as I advise you, I can receive your questions through my email or through the messenger, and probably later on we will do some sessions especially for the questions through the Zoom program. So by the end of this lecture, I hope every students now he knows the epidemiology of meningitis, pathogenesis of meningitis, the clinical picture of meningitis, diagnosis of meningitis, the treatment of meningitis, the different types of meningitis, and prevention of meningitis. Thank you very much, and see you in future